Hello and welcome back to our free flowing series. Today again we are joined by Buddy Fuda from UT Southwestern, and he's going to talk about a very interesting topic, normal populations of certain cell types that we don't think of but may become important in some cases, and those are basophils, NK cells, and plasmacytoid dendritic cells. So without further ado, I'm going to ask Buddy to share his slides and take over. All yours, Buddy.
Okay.
Yeah, if you want to put that on the slideshow.
Okay, yeah. All right, Nitin, thanks for having me back. Happy to be here. Today I'm going to talk about the immunophenotypic characteristics of three normal cell types that have subsets of cells that have some immunophenotypes that can be confusing sometimes when you're looking at them if you don't recognize that these subsets actually show this kind of expression of these type of markers, and particularly when we're looking for minimal residual disease in certain acute myeloid leukemias, these subsets can cause some confusion as to whether you're looking at a neoplastic cell population or a normal cell population. So the three cells we're going to talk about are basophils, NK cells, and plasmacytoid dendritic cells. So we'll start off with commonly used plot CD45 versus side scatter, and we're really interested in this area here. So this area is the area that sits between the T and B lymphocytes, the monocytes, and the blast gate. So the first cell population that we'll talk about that sits in this area are NK cells. And so if you look here, and if you color the T lymphocytes and the B lymphocytes in green, you can see that the NK cells in general have dimmer expression of CD45 and slightly increased side scatter than the other lymphocytes. And then again, you can see the remainder of the cell populations in a bone marrow and where the NK cells sit in relation to those cells. Now, depending on the system that you have and the setup that you have, so depending on your flow cytometer, the fluorochromes you're using, your compensation settings, and then importantly, your lysing agent that you're using, the actual expression of CD45 and the side scatter on NK cells can vary slightly. And so in this second says, here's the first system that I showed you, and here's a second system here where you can see that the NK cells are in blue still and the T and B cells are in green, but there's not nearly as distinct a separation from the NK cells here. So you still, on average, you get a slightly dimmer CD45 and a slightly increased side scatter, but they don't come out quite as far. So you have to basically know where these guys sit in your own system and what you're using. All right, so let's talk a little bit more about the NK cells. So NK cells go through maturation in the bone marrow, and I'm going to put up a laser pointer here. And you can see that they express a lot of different markers. And we really don't have the time today, nor do I have the actual expertise to talk about every single one of these markers. So what we're going to focus on are the markers that we routinely look at in our laboratory for NK cells. So markers like CD2, CD5, 7, 8, 11B, 16, 45, 56, and 57. Now, I'd already mentioned that the NK, or where the NK cells sit on CD45 and side scatter. If we go over here to the physical parameter plot and we take a look at forward light scatter, we'll see that NK cells in general show slightly higher forward light scatter than the T cells, which are painted green here, and slightly, again, increased side scatter than the T cells. If we were to look at CD56, we'd see that most of your NK cells are going to express CD56, although there will be a few NK cells that do not show expression of CD56. Now, NK cells have a lot of different subsets functionally and depending on their differentiation and maturation states. And you can see here, there's two broad subsets here. There's a CD16 negative subset and a CD16 positive subset. Looking at CD7, that's an important marker that we always assess when we're looking at NK cells. And you can see here that the bulk of NK cells are going to be positive for CD7. Now, if we look over here, this one, this is a bone marrow. This is a peripheral blood sample. But you can see this one's a little bit exaggerated, but it really shows the point that I'm trying to make here is that NK cells on average show slightly brighter expression of CD7 than the T cells. And this comes into play when you're looking at specimens that have Hodgkin, classical Hodgkin lymphoma in them, because you can actually look for the helper T cells, and they will show oftentimes brighter expression of CD7 on those helper T cells. And so when we see the expression of CD7 hit the intensity of the NK cells and even go beyond, you know, that just kind of makes us think, oh, could this possibly be classical Hodgkin lymphoma? Now, it's important to remember that that is not a specific feature, but it is one that can be seen in classical Hodgkin lymphoma. All right, going back up to CD7, I'd mentioned that your bulk of your NK cells should be CD7 positive. You can have small reactive subsets that are CD7 dim positive, and you can even have small subsets that are CD7 negative. All right, now, if you see an expanded population of NK cells that are CD7 negative, you're going to really want to pay attention to that and do a really good, careful immunophenotype on it, because more than likely that's going to turn out to be neoplastic. So you really don't see large populations or large subsets of NK cells drop CD7, but it is important to be aware that you can have some small subsets that don't express CD7. All right, moving on to CD2, we can see again, you have two broad categories of NK cells here. You have CD2 negative NK cells, and you have CD2 positive NK cells. Looking at CD8, our NK cells are typically partial dim positive for CD8. And you can see here, there's a few cells expressing CD5, and I'll mention that again in another slide coming up. As far as CD11B goes, the vast majority of your NK cells are going to show expression of CD11B, and you can have a few cells here and there that don't have CD11B expression. And then CD57, you're typically going to see a subset of NK cells express CD57. Okay, now so we can kind of make out here that you've got different subsets of NK cells, and you can kind of see those based off of the different expression of these different markers that they have. And these subsets are going to correlate to different stages of maturation, different stages of differentiation, and then also different functional subgroups of NK cells. So if we look here at NK cell maturation in the bone marrow, NK cells do, start to life as a hematopoietic stem cell, and then, those will mature and they'll differentiate into NK cells. And although there's a lot of subsets of functional NK cells in the body, we generally think of two when we're talking about hematopathology. So the first one that we think about are the CD56 bright positive, CD16 low to negative subset of NK cells, and this second subset that's CD56 dim positive and CD16 nicely bright positive. So this first subset is generally involved in immunoregulation, and the second subset is generally involved in cytotoxicity. And then there's some thought that you get some maturation from this first subset into the second subset here. All right, so this is an actual plot that shows CD56 versus CD16, and we can see these are our two broad subsets of NK cells. Here's the first subset that's 56 bright and 16 negative, and here's that second subset that is 56 dim and 16 nicely bright positive. But we know in reality, if you were to look at multiple cases, you're going to identify that there's far more subsets just based off the expression of 16 and 56 that exist. So here we have 5 subsets, the 2 that we talked about. Here we have a subset that's still CD56 bright positive, but CD16 dim positive. We've got a subset here that is 56 dim positive and 16 negative, and then a subset here that is actually 56 negative and 16 bright positive. So again, just looking at these two markers, you can make out different subsets of NK cells. And then if we were to look at other markers of NK cells expressed, you could even pull out more subsets. But for immunophenotyping leukemia and lymphoma, we don't generally have to worry about all those different subsets of NK cells. So we want to be able to go in, and we're going to be looking for deviation from normal. So we just want to know what normal in general looks like. And when we see deviation for that or difference from normal, that's when we get concerned that we might be dealing with some type of neoplastic or malignant process. So here in the peripheral blood, you can see that the bulk of the NK cells are going to be represented by these CD56 dim, CD16 bright positive cytotoxic NK cells, and those will actually make up normally more than 90% of the total NK cells in the peripheral blood. Now it's important again to remember that you do have some CD56 negative NK cells here. And why is that important to remember? Well, sometimes they can get expanded. So if I was looking at this plot and I was in a peripheral blood and I'm assessing my NK cells and I saw a big glob of CD56 negative NK cells, I'm going to be concerned that I could be potentially dealing with some type of neoplasm. And so I'd pay a lot of attention to all of my NK cell markers. But in the back of my head, I'm also going to keep in mind that there are normal conditions where you get an expanded population of CD56 negative NK cells. And three of those conditions are HIV, CMV, and then hepatitis C viral infections. So this patient here happened to have HIV and had an expanded population of these 56 negative NK cells. Now here's a case in the peripheral blood where you actually have a shift toward those CD56 bright positive, 16 negative NK cells. And so again, if I saw this in the peripheral blood, I'd want to be real careful to pay attention to all of my NK cell markers to ensure myself that I'm not dealing with some type of neoplastic process. But in the back of my head, knowing that you can get expansions of NK cells above 10% under certain circumstances. One of those circumstances is after bone marrow transplantation during reconstitution of the immune system. You can see this kind of a shift. There's also certain diseases that you'll see this kind of a shift in the NK cells associated with them. And so you can look at the references 4 and 9 that that's on a slide here, a couple slides beyond this one, and they actually talk about some of those diseases that you'll see a shift in the proportions of NK cell subsets. Okay, if we go to the lymph node or tonsil, we kind of get the opposite picture. So here you can see that the bulk of your NK cells in the tonsil or lymph node are going to be made up of those CD56 bright positive NK cells. Now I didn't have a CD16 to look at in combination with the 56 on any lymph nodes, so I couldn't show you what this, that's what these cells were. But CD2 is also bright positive on those CD56 bright positive, 16 negative NK cells. And so here you can see these are the cells here that represent that subset. Now, this is pretty much the mirror image of what you expect to see in the peripheral blood. In lymph node or tonsil, you expect to see the CD56 bright, CD16 negative subset of NK cells representing 90% or greater of the total NK cell population. So we're going to shift gears back to the cytotoxic subset that's 56 dim positive and 16 positive. So this subset here, and what we're going to show is that this is actually the subset that is going to express your killer immunoglobulin-like receptors. Okay, why is that important? Well, we can look at that subset. So here in this paper, they looked at this and they gated on those CD56 dim. So that would represent your CD56 dim positive, 16 positive NK cells. And then they looked at the KIR pattern of expression. And what they see is that it's a nice polyclonal type of pattern. So if you look down here at the KIRs, you can see you've got different subsets that are expressing different KIRs. And that's important because that's a normal pattern that you should see. If you get an abnormal pattern, then you may be dealing with a clonal expansion or neoplastic NK cells. So you can use this KIR analysis in a similar fashion that you would use immunoglobulin light chain kappa and lambda and B cells, and say TCR beta 1 analysis in T cells to try to identify clonality in the natural killer cells. Now, going back to all these different markers that NK cells express, I want to focus in here on CD117 because this is a under-recognized population of NK cells that can really create confusion when you're looking at leukemia lymphoma workups, especially for MRD. So here again, you know, it's important to recognize that these NK cells that are CD117 positive do in fact exist. So why is that important? Again, during MRD analysis for CD117 positive T lymphoblastic leukemia lymphoma, during MRD analysis for early T cell precursor acute lymphoblastic leukemia, for mixed phenotype acute leukemia T myeloid, and even just AML itself, all of these diseases here can share expression of NK cell markers and CD117. So it can be really tricky and confusing if you're seeing a population of 117 positive cells that have CD7 and 2 on them, and you're not aware that normal NK cell subsets do that. You might overcall minimal persistent disease of one of these guys, and in reality, it's not. It's an NK cell subset. So again, these 117 positive NK cells are going to be represented predominantly by that first broad category of NK cells, the 56 bright positive and 16 dim to negative NK cells. Now, we're in the bone marrow, and you'd expect, yeah, okay, it makes sense that, you know, immature NK cells can be identified in the bone marrow. But the reality is NK cells also develop in extramedullary sites, and you're going to see these 117 positive NK cells in these extramedullary sites. So they've been reported in lymph nodes and thymus and liver and the uterus. You can see here, they're in peripheral blood. We've even seen them show up in cerebral spinal fluid. So we actually had a case that we were looking at. It was a follow-up of a CD117 positive T lymphoblastic leukemia, and we were looking in the cerebral spinal fluid, which are typically low cellular specimens, so you only have so many tubes to look at. And we had this nice little population of CD117 positive NK cells in there that were kind of mimicking our T lymphoblastic leukemia lymphoma. So since we were aware that, you know, these things do exist, we were very cautious and made sure that we didn't overcall the CSF positive for T lymphoblastic leukemia. Okay, there's a couple more interesting immunophenotypic features of NK cells that people should realize do happen. One of them is the CD5. So I mentioned earlier I was going to bring up CD5 again in NK cells. And, you know, I think traditionally we think of NK cells as CD5 negative, but the reality is that there are little subsets of NK cells that do express CD5. And these can be quite expanded to where they're easy to see. Usually you only see a few cells picking up CD5 that are NK cells, but these guys can get expanded. It's not all that uncommon to see very distinct little subsets of CD5 dim positive NK cells. So it's just important that you're aware that those do exist, not to overcall those as some type of aberrant population. Or maybe even more important than that is to recognize that there are subsets of NK cells that show expression of CD33. So it's going to be typically dim expression of CD33. And if you look at the 33 here plotted against CD117, you're going to see that the bulk of the cells that express CD33 are in fact those first subset of NK cells that are CD117 positive, 56 bright positive. So here again, you can see the 33 positive guys are 56 bright positive. They happen to be 16 mostly negative, and then CD2 bright positive. So just important to recognize that yes, there are subsets of NK cells that express CD33. They happen to be that same subset for the most part that expresses CD117. Last thing we want to do is overcall minimal persistent disease in a myeloid leukemia or like a mixed phenotype acute leukemia T myeloid that also expresses those kind of markers. So we just need to recognize that yes, in fact, these NK cell subsets exist, and we want to make sure that that's not what we're dealing with when we're doing MRD analysis. Okay, so there's some references for the NK cells. If anyone wants to look these up, there's some really nice descriptions of the different subsets of NK cells in the immunology research. They've really gone through and they've characterized a lot of these NK cells. So it's fascinating reading if someone has the time. We don't deal with that nearly as much in hematopathology when we're looking for leukemia lymphomas, but very interesting topic. Okay, so what else sits here in this site that we were talking about in this general area? Okay, two populations that I would focus on are plasmacytoid dendritic cells here in red and basophils here in blue. So you can see I've got painted here green. These are monocytes. These black guys are non-classical monocytes here, tend to have a little bit brighter expression of CD45 than your classical monocytes. And then again, in this little pocket here, you're going to find plasmacytoid dendritic cells and basophils. And, you know, in this case, the plasmacytoid dendritic cells are slightly brighter for CD45. But the reality is, in most scenarios, they're going to sit with each other, exactly with each other on this plot. I'm talking about the plasmacytoid dendritic cells and basophils. Okay. So here's our physical parameter plot again. If we look at the forward light scatter, we can see here painted in red, our plasmacytoid dendritic cells have kind of moderate forward light scatter and low side scatter. So they kind of sit directly below our monocytes that are painted green here. And then you can see the basophils, they show slightly higher forward light scatter than the small lymphocytes here that are gray in the background. Okay, and slightly higher side scatter than those small lymphocytes. So really, they kind of sit in this little pocket here between the monocytes and the plasmacytoid dendritic cells. So the basophils, again, in blue. Now, if we were to look at CD123, I think most people recognize that both basophils and plasmacytoid dendritic cells have nice, bright expression of CD123. So if we look up here, here's our basophils in blue, our plasmacytoid dendritic cells in red, and we can differentiate between the two by looking at HLA-DR. Our plasmacytoid dendritic cells will be positive for HLA-DR, and our basophils will be negative for HLA-DR. Now moving over here, we see CD303 on the y-axis here. That is a specific marker for plasmacytoid dendritic cells, and we can see here that they're nicely positive for CD303, whereas the basophils here in blue are nicely negative for CD303. Now CD56 is an important marker to look at. Specifically, you can see that your basophils are negative, but in particular, you want to look at that and see that here your plasmacytoid dendritic cells are predominantly negative for CD56, but there will be small subsets of plasmacytoid dendritic cells that actually do express CD56. So that's really important to recognize. Why? Well, that's a very characteristic immunophenotype of the malignant counterpart of normal plasmacytoid dendritic cells, the blastic plasmacytoid dendritic cell neoplasm. So, you know, when we see a population of plasmacytoid dendritic cells expressing CD56, this is the first thing we think of. But we got to remember, if it's not an expanded population, it's only a small population, keep in mind that actually there are little subsets of normal plasmacytoid dendritic cells that do in fact express CD56. These blastic plasmacytoid dendritic cell neoplasms, again, you'll see an expanded population typically of 56 positives, and oftentimes they're slightly brighter intensity of CD56 on these guys than on the normal guys. Okay, when we talk about CD11C, we can see here that our basophils painted in blue are nicely kind of moderately positive for CD11C, and our plasmacytoid dendritic cells for the most part are negative. Now, if you look, you can look at that and you go, well, buddy, now wait a minute, this thing looks like it's riding right up here on this this y-axis. Why are you calling it negative? Well, again, this is due to predominantly due to artifact and compensation issues, basically. So for the most part, your plasmacytoid dendritic cells should be CD11C negative or very dim positive at best for CD11C. Now, CD4 is an important marker on plasmacytoid dendritic cells, and it's important to recognize that plasmacytoid dendritic cells can actually have different intensities of CD4 expression, dependent on the tissue type that you're looking at, and potentially the specific, type of plasmacytoid dendritic cell, I suppose. The reason that's important, we know that when we're looking for leukemia lymphoma, we're not just looking for positive and negative expression of markers, we're also looking for the intensity of expression, and we're trying to identify abnormal intensity so that we can say that, okay, that population, even though it's positive for this marker, it is not expressing it at an intensity that's expected for normal. So with plasmacytoid dendritic cells, again, depending on the actual specimen that you're looking at, you can get different intensities of expression of CD4. So sometimes you can see them sitting down here where they're dim positive for CD4 at the level of these monocytes that are painted green. And sometimes, like in this case, you can see that they have nice bright expression of CD4 at the level of the T lymphocytes or the T helper lymphocytes here in the background that are gray. Okay, so CD2 is another marker that is going to be partial positive in plasmacytoid dendritic cells. That's just normal. And negative in basophils. And I forgot to mention that your basophils are negative for CD4 over here, right? Okay, now, so this is, again, important to recognize this. It's important to recognize these markers that can be positive in plasmacytoid dendritic cells, because you don't want to mistakenly think that these are abnormal T cell populations. So, because plasmacytoid dendritic cells are going to be CD3 negative, and they'll show expression of CD2. They can have a little bit of CD7, things like that. So you don't want to mistake those as a T cell, an abnormal T cell population when you're really dealing with, or what you're really dealing with, are plasmacytoid dendritic cells. Now, CD22 is a very important marker for us, and I'll explain why on the next slide. But here we can see that both our plasmacytoid dendritic cells and our basophils express CD22. Now, in this particular case, the plasmacytoid dendritic cells were a little bit dimmer for CD22 than the basophils. They're usually about the same level of intensity. You can get some variation, though, depending on the case. Now, if you're looking at this, you might be saying, hey, wait a minute. I know that CD22 is a B-cell associated antigen. I see you've got the basophils painted blue and these plasmacytoid dendritic cell things painted red. Where the heck are the B cells? Well, in this case, there just weren't any B cells because the patient had been treated previously with rituximab. If there were B cells, you'd see they'd sit up in this region because they'd be brighter. The mature B cells, that is, would be brighter for CD22 than both the basophils and the plasmacytoid dendritic cells. Now, I mentioned that CD22 is really important. Why is it important? Well, in today's era, we use CAR T19 therapy for several different diseases. One in particular is B lymphoblastic leukemia. And so when we treat patients with CAR T19 therapy, what happens is that the follow-up cases, your B lymphoblastic leukemia can come back as a CD19 negative B lymphoblastic leukemia or B lymphoblast population. So we have to find most people, we don't do a rigid gating analysis in our laboratory. So we use, a different type of approach than, the traditional rigid gating analysis. But if you were doing a rigid gating analysis, you're going to end up using, surrogate markers for CD19 as your B cell gating marker. And one of the markers that is used is CD22. So if we're using CD22 to gate our B cells and we're looking for, lymphoblasts, it's going to be really important to recognize that in that gate, you're not only going to have lymphoblasts, but you're going to have basophils and plasmacytoid dendritic cells. So over here, you can see this is a clone SHC1L1. This is probably the most common clone that's used for CD22 in probably the majority of flow cytometry labs. And you can see painted green here are my B lineage cells. The guys that are brighter for CD22 up here, those are mature B cells. And the guys that are dimmer for CD22 down here, these are your hematogones or your immature B cells. Now, B lymphoblastic leukemia will typically express 22 at a dim level, similar to your hematogones. And you can see that level of intensity is exactly the same level of intensity that your basophils painted blue here and your plasmacytoid dendritic cells painted red here show for CD22. So you could, if you wanted to, you could get a clone that is supposed to be specific for B lymphocytes or B lineage cells. So this HIB22 clone is I would say, more specific for B lineage cells. You can see here, your basophils do not stain for CD22 using this clone. But in our experience, your plasmacytoid dendritic cells, these guys are negative for CD22. But see this little subset right there? Those guys are still DIM positive for CD22. So when we tested this clone and took a look at it, we saw that we were still getting staining on a subset of plasmacytoid dendritic cells at that DIM level. And so, you know, we chose to stick with this HCl1 clone, particularly because it would be helpful in the fact that it gets rid of most dendritic cells and gets rid of most of your basophils. But if you look at the intensities here, the HIB22, at least when we tested it, showed lower intensity of expression or of staining than the SHCl1 clone. And so since we're interested in this DIM positive area, we wanted to get it as bright as we possibly could. So we stuck with this clone. Okay. So as far as basophils and plasmacytoid dendritic cells go, we can look at some other markers. So other T cell associated markers, you can see that your basophils are negative for CD7, and the vast predominance of your plasmacytoid dendritic cells are also negative, but you can get small normal subsets of plasmacytoid dendritic cells that do express CD7, so just be aware of that. These things don't, I mean, they're not going to ever be a big population. So, you know, if you see a really expanded population of plasmacytoid dendritic cells expressing CD7, that's going to clue you off that there's a good chance you're dealing with a blasted plasmacytoid dendritic cell neoplasm. So, but just keep in mind that, you know, if you see a small subset, that does not mean that it has to be neoplastic. Okay, similarly with CD5, you can get small subsets of plasmacytoid dendritic cells that are positive for CD5. We see this subset quite frequently. And then your basophils painted blue here should be negative for CD5. As far as myeloid markers go, basophils painted blue here have nice, relatively high intensity of expression of CD13, kind of at the same level as your monocytes here. Okay, whereas your plasmacytoid dendritic cells are negative for CD13. If you were to look at CD15, oh, I'm sorry, let's go back up here for CD64. Both basophils and plasmacytoid dendritic cells are negative for CD64. Okay, now CD15 is going to be typically negative or normally negative on both plasmacytoid dendritic cells and basophils. Okay, so you can get a few basophils picking up DIM expression of CD15, but for the most part, they should be negative. Now, you know, you kind of need to know your own system to know where these populations sit. And you can see that, again, both of these populations are coming off of the origin for CD15, but that's just due to the way we have our system set up in our compensation. We like to push it off here a little bit to get a little bit better look at the spread here. So this truly is negative for CD15 up to this level here. All right, now CD33 is interesting. You can see here that our basophils painted blue are kind of moderately, some people call this DIM, positive for CD33. That gray blob in the background there, those are your neutrophils, okay, or your granulocytes. So the basophils have the intensity of CD33 expression at about the same level as your granulocytes do. All right, plasmacytoid dendritic cells. This is an interesting case here because it looks like they're positive, doesn't it? All right, so let's just go back over here. So let's focus on the plasmacytoid dendritic cells. Your plasmacytoid dendritic cells, if you look at most of the literature, are going to tell you, or most of the literature will show that plasmacytoid dendritic cells do not have expression of CD33. We can see here we've got a few cells that are positive for CD33. And in our experience, and I know there's a few other labs that have seen this as well, we actually see plasmacytoid dendritic cells pick up CD33 sometimes. So you can see it in that case there. You can see it in this case here. So it's just, you know, important to keep this in the back of your mind because CD33 expression is sometimes described as, or, you know, described on the blastic plasmacytoid dendritic cell neoplasms. But again, it's just important not to use that by itself as a determining feature for malignancy, because we have seen plasmacytoid dendritic cells pick up CD33 expression. And we've done FMOs and control tubes just to make sure that that does appear to be true staining. Okay, other markers to pay attention to. CD11B is going to be nicely positive at a moderate intensity here for basophils and negative for plasmacytoid dendritic cells. Importantly, basophils have nice bright expression of CD38, and plasmacytoid dendritic cells have nice moderately bright expression too. So you can see in neoplastic populations, you can see a decrease in CD38 on these populations. CD9 is a nice marker for basophils, and you can see here blue on the x-axis here. The basophils painted blue are nicely positive. In this particular case, you can see that the plasmacytoid dendritic cells were negative for CD9. But shifting gears over here to the y-axis, that's where our CD9 is here. You can see again our basophils now have nice expression, and in this case, you can see that our plasmacytoid dendritic cells are actually picking up some CD9, so they can pick up some CD9. As far as CD36 goes, you can see that your plasmacytoid dendritic cells are nicely positive for CD36. Now, basophils can be positive or negative for CD36. I've seen cases where they're completely negative and cases where they're nicely positive. I've seen cases where they're partial positive. And that's also mentioned in the literature. One thing to keep in mind anytime you're looking at CD36, always pay attention to your background neutrophils. And the reason is normal neutrophils don't express CD36, but platelets do. And platelets are sticky, so they can stick to your normal cell populations. So if your neutrophils show staining for CD36, then you have to take everything else with a little bit of a grain of salt, right? You gotta realize that you may not have true expression of CD36. It might just have neutrophils adhered to it. And in this case, you can see this big blob of gray back here. These actually are neutrophils. They ought to be sitting over here, and they're showing staining for CD36. So this case here did in fact have platelet adherence to our cell populations. Okay, as far as CD45RA goes, you can see here that our plasmacytoid dendritic cells are nicely positive for 45RA, and our basophils are negative. And then for CD25, you can see our basophils are nicely positive. Well, okay, shouldn't say nicely. They're dimly positive for CD25, and the bulk of our plasmacytoid dendritic cells are negative. The CD25 expression on basophils can be dropped in neoplastic scenarios where the basophils are part of the neoplasm. Okay, as far as CD117 goes, our threshold is over here, okay? So both our basophils and plasmacytoid dendritic cells, for the most part, should be negative for CD117. The reason I pulled this plot in here is specifically for the basophils. In a lot of our chronic myeloid leukemias, where we have basophils that are part of the neoplasm, you can see them pick up CD117. You know, you're probably getting an expansion of immature basophils in those scenarios. The other, I think we've seen one acute basophilic leukemia that the basophils were uniformly positive for CD117. Now, I know some of the literature doesn't mention 117 on acute basophilic leukemia, but at least that was our experience with that that single case we had, and logically it kind of makes sense. So anyhow, I pay attention to CD117 on my basophils, and if I see an expansion of CD117 basophils, I worry a little bit about a potential myeloid neoplasm. I'm not going to use that alone to call something a myeloid neoplasm, but I'm going to be a little bit more careful. Okay, and then lastly, it's really, really important to recognize, specifically in the plasmacytoid dendritic cell population, that you do have immature plasmacytoid dendritic cells that will be CD34 positive, and those will show up if you're doing any kind of minimal residual disease type of analysis. You're going to see these guys show up quite frequently, and even in a routine analysis, we look at 100,000 events basically, and we routinely see these CD34 positive plasmacytoid dendritic cells. So it's just real important to recognize that they do exist. And these are the references for papers discussing some plasmacytoid dendritic cells. This link here to these to the cytometry.org, these are really nice short presentations written up by some of the members of ICCS. And so it's a really nice place to go look for some really short, succinct descriptions of different cell types and different diseases. And then again, we have some references for basophils. And so that is all I have for today.
All right, buddy. Thanks a lot. So this is a fairly difficult topic to put together. So you did a really great job in describing these populations that people don't think about all the time. But certainly, like you mentioned in MRD analysis, these can create diagnostic issues. And there's a lot of variability in the phenotypes that all these three populations can show even under normal circumstances. So you warned us about not jumping to conclusions about them. So thanks a lot. And let me see here, let me stop recording.